Good afternoon, everyone. Welcome to our talk. Thank you all for coming for our event today. My name is Megan Taves. I'm a research associate at the Health Law Institute here at the law faculty. And we have several organ donation and transplantation related projects under the Canadian National Transplant Research Program and Canadian Blood Services. And it is our pleasure today to have Dr. Stephen Bede with us to talk about presumed consent for organ donation. And before I turn things over to him, I'm just going to go through a couple quick slides to provide some background information and some context for the discussion here today. So presumed consent for organ donation has been in the media a lot over the last year, particularly as a potential mechanism in Nova Scotia for their consent system for organ donation. And that's one of the reasons why we're so fortunate to have Dr. Bede here with us today, all the way from Halifax, so he can share with us some of his insights into this debate that's going on in his province. But before we get into that, I thought it would be useful to quickly go over what we mean when we say presumed consent and how this differs from the current consent framework that we have in Canada at the moment. So the Canadian system that we have is one of explicit consent, or it could be called an opt-in system. And this means that in order to be an organ donor, an individual has to provide an explicit positive statement indicating their consent to donate. And if they haven't consented, then in some circumstances, their next of kin or surrogate decision makers then have to give also an explicit positive indication of their consent to donate their loved one's organs. Whereas in a presumed consent system or an opt-out system, essentially everyone is deemed to have already consented to become a deceased organ donor unless they have specifically opted out by giving some sort of explicit statement indicating that they do not wish to be an organ donor. So the default in presumed consent is that everyone is essentially an organ donor unless you have opted out, whereas in the Canadian or other explicit consent jurisdictions, the default is you are not an organ donor unless you explicitly consent to be one. And presumed consent has been gaining popularity around the world. Different jurisdictions have implemented presumed consent systems. These are some examples of different countries that have some form of presumed consent, many of which are in Europe and South and Central America. But in Canada, consent for organ donation is regulated under provincial and territorial legislation that governs organ donation. So each province and territory essentially has their own piece of organ donation legislation that sets out the requirements for providing consent. And so with regard to who can provide consent, under the legislation, essentially anyone can provide consent so long as they have attained the minimum age for doing so. So in Alberta, that is 18 years old, but it varies from 14 to 19 years old, depending on what province or territory you live in. And consent can be given in writing, and in a lot of jurisdictions, it can also be given orally by the donor in the presence of at least 2 witnesses during the donor's last illness. And in Alberta, there are a few specific means through which you can indicate your consent, one of which is signing the back of your healthcare card. And we also have recently implemented an organ donation registry where you can register your consent to donate when you renew your driver's license or by going online. And under the legislation in most provinces and territories in Canada, the legislation provides that consent for organ donation is legally binding and full authority to proceed with organ procurement. And what this means is the legally binding part means that under the law it's something that should be followed, and full authority means that it's sufficient in itself to proceed with organ procurement. And that means that no additional consent or authorization from anyone else is necessary in order to proceed with organ donation. Whether this is actually enforced in practice is a whole other question that we could probably devote an entire lunchtime session to discussing. But suffice to say, for our purposes here, under the law and the legislation, your consent to donate is legally binding and sufficient. That said, there is an exception in the legislation that you can withdraw your consent and you can change your mind, and so the legislation provides that no one should act on a consent if there is reason to believe that it has been withdrawn. So how does Canada fare compared to other countries in our deceased donation rates? This is a chart comparing deceased donation rates from 2013. It should be noted that different countries have different methods of reporting their organ donation statistics, so this may not be completely accurate, but it provides sort of a general picture of where Canada stands compared to other countries. So at the top end of the chart, we have Spain as well as Croatia, which are the two countries with the highest deceased donor rates. And then we have the United States, which is also a pretty high performing country when it comes to deceased donation. And then over there we have Canada. And so Canada is kind of in the middle of the pack here. And so presumed consent is being discussed as a potential way to increase deceased donation rates. And that's one of the reasons why it's being discussed in Canada, is because we're not considered to be a very high performing country. And so it's important to consider which of these countries on this chart actually have presumed consent systems. So all these little orange arrows indicate countries that have implemented some form of presumed consent. And so you can see on the high end of the chart there, a lot of the top performing countries have implemented presumed consent systems, but so have some of the countries on kind of the lower end of the chart as well. And then you also look at countries like the United States, which has a very high deceased donor rate, but they have an explicit consent system, much like we do in Canada. And so this raises questions about whether it's presumed consent that's leading to these higher deceased donation rates, or maybe there are other factors and aspects of deceased donation systems in these countries that may be having a lot of influence over that as well. So as this debate unfolds in Canada, it's important to consider whether presumed consent would be effective at increasing donation rates in Canada. Additionally, it's important to consider whether presumed consent aligns with Canadian values. In Canada, we have a lot of respect for individual autonomy and patient decision-making, and there are some concerns that presumed consent might create a backlash. And if we think that it would be effective and that it would be publicly supportable, then as a practical matter, it's also important to consider what changes to the law and policy and practice would be required to implement a system like that here in Canada. So I will leave those questions with you to think about as the debate unfolds and as Dr. Stephen Bede comes up to talk to you more in depth about presumed consent. And so it's my pleasure to introduce Dr. Stephen Bede to you all here today. Dr. Stephen Bede was a graduate of Dalhousie Medical School. He served as a general duty medical officer in the Canadian Armed Forces and completed his residency in anesthesia at Harvard University, where he also completed subspecialty training in adult critical care medicine. He worked as an attending physician in Boston and helped establish a training program in surgical critical care while working as an intensivist there. He subsequently returned to Halifax, and in his role as the head of critical care medicine, he was the medical lead for the development of Nova Scotia's organ and tissue donation program, Legacy of Life. He presently serves as the chair of the National Deceased Donation Advisory Committee with Canadian Blood Services, and he is a professor of anesthesia and critical care medicine at Dalhousie University. Additionally, he serves as the program director for the Royal College of Physicians and Surgeons of Canada training program in adult critical care medicine. So please join me in welcoming Dr. Stephen Bede to talk to us more about presumed consent.
Well, thank you very much, Megan. I appreciate the invitation. I'm going to come at this not as a lawyer. Obviously, I'd be a fool to talk law in a law school. I come at this as a clinician. You know, I have administrative hats and education hats, but the real reason that I do what I do is because there's patients. So I'm going to speak to this issue through that lens mostly, and some of what I'm going to say will be reinforcement of what Megan went over, but we'll talk about some other things. First of all, I feel obliged, no financial disclosure. Thank you for the invite. Obviously, it's been a bit of a challenge to get through Canada in the winter, but I'm here. Acknowledgements, CBS have been a huge supporter of this, and I've got some slides from colleagues from the ISODP, and I need to acknowledge their participation as well. So let's get on with what we're going to hopefully cover in the next little while. The Canadian perspective on this, to some extent, I think is worth talking about so that we at least know where we're coming from. A little bit about presumed consent, but I'm obviously going to be able to fly through that quickly because Megan did a great job on that. We'll talk about where it's used, and then maybe a conversation around what's been happening in Nova Scotia and my opinion, for whatever it's worth, on maybe what will be happening in the next little while. So there's a relatively full agenda, and we'll state some obvious things. Well, I shouldn't say that. It's obvious to people within the community, but for a diverse audience, I don't know where you're coming from or what your knowledge might be around the organ and tissue donation world, critical care in Canada. So I'm going to presume that people are familiar with the fact that there's clearly a problem with the supply of organs. We need more, and that Canada, as Megan has pointed out, for its wealth and its advanced medical systems, has modest performance. I include London because London, I think, is the most successful single academic center in Canada with a donor rate in the low 20s. We're pretty darn close to them, but we're not up into the 30s like others. So having said that Canada is modest, I think there's reason to be very proud of what's happening now. And that, as you can see, is that in spite of starting at a modest place, we are starting to see real, tangible, honest-to-God gains. A lot of work is going to take some time to develop momentum, and I think we're starting to see the result of what work was done 5 or 10 years ago. 33% increase in donors is important, and that translates into almost 40% increase in transplants. Now, the disappointing part of this is that in spite of that, the gap still increases. So we can't congratulate ourselves on success when we still have patients who are needing our help. So it's a problem. And with that as a background, it sort of seems obvious to a lot of people that given that there's thousands on the wait list, there's people dying, we know from public opinions that the public say they support this, why not assume everybody's a consent or a donor unless they don't? There's the crux of presumed consent. So the Canadian perspective in terms of information, this is CBS survey data, fairly recent, mostly done in this particular case with healthcare professionals, and I did that intentionally. The general public at large support donation. They may not know exactly what they're supporting specifically, but they support donation. We'll leave it at that. But these are healthcare professionals, often at the front line, and what's their feeling on organ and tissue donation? And it's important, I think, to reinforce that even in the healthcare community, there's overwhelming support for organ and tissue donation. It's a very important thing. We're talking about roughly 90-95% for sure, and professionals know it's important, they're supportive of it, but then things start to fall apart a little bit when you start to look at how confident that these frontline healthcare practitioners are that the wishes of the deceased are going to be respected. This is a little concerning to me, but it's a reality, and it gets worse when we talk about this. This is what is happening at the bedside. And what you can see there is these frontline healthcare practitioners think that when there is a conflict between what the patient wanted and what the family at the bedside want, about 3/4 of the time, the family wish is prevailing. And about 70% of the time, they don't think that's what should happen. So that's a pretty important disconnect. It's a reality, and I've seen this over and over again. These are not funny numbers. But it's an issue that, as a community, we need to talk about. And in terms of support amongst this cohort for changing to presumed consent, there has been a slow but significant increase in support for this over the last 5 or 10 or 15 years, and we are now roughly 55%. So the majority of healthcare practitioners and Canadians now support presumed consent, but it's just about 50-50. It's a pretty close to an even draw, but the momentum is towards supporting that. That's a somewhat scientific review of the public. Now, this is non-scientific, but this is pop culture, this is relevant. You can look at the data that you got from this Globe and Mail poll, and it's nowhere near the sort of 50-50-ish split. It's fairly overwhelmingly against switching to presumed consent. And these are attitudes in countries, UK. You may or may not know that the Welsh legislature has just approved presumed consent. And so a bunch of polling was done in anticipation of that. And what they saw over time was gradual increased support for presumed consent, but ballpark 60%. Now it's their law. So if you distill it down, you can say that there is evolving support for presumed consent, but it is not a slam dunk when you talk to this, either the public or healthcare professionals for it. The whole consent thing is an interesting thing for a frontline clinician versus a lawyer. Lawyers have a very clear idea that we need to be crystal clear on this. I've seen thousands of procedures over a few decades. I'm not sure how many would have truly informed consent in the way that we would like it to be honest. That's not a strength, but that's a reality. There's an awful lot of things that I've seen people, they don't have their glasses. God knows what time they slept, and the surgeon is saying, we talked about this, just sign here. Where? Take their finger. That's not valid consent, and off they are to the operating room. So this whole consent thing, totally different conversation, but an important one. I'm not defending that reality. I'm saying it's one of the problems with our system. But the notion that presumed consent is a problem because it's not truly informed is part of a broader conversation around how often we have informed consent about anything, to be honest. So if you do have consent, I won't go through this because Megan went over it, and you may be lawyer types, which means you'll stump me in a blink. The World Health Organization, again, you don't need to read it, but it's readily available. It more or less distills down to what Megan went over. But the opt-in, opt-out, and the hard and soft terms are things that you should be fairly clear on. Presumed consent means that you're going to be a donor and you have to do something that opts out of that, and and that is an issue for some people. In some countries around the world, using the hard opt-out means that essentially what the donor said is what we're going to do, period, full stop. And if a family want to get involved, they're ignored. That hard opt-out actually doesn't really happen very often. It's on the books, but in reality, that's not what you're seeing. The soft opt-out is what happens in a lot of places. And in light of the conversation around informed consent and the fact that these patients are dead, a term that I've heard used, and I don't know who to attribute it to, but it resonated, but presumed authorization actually makes more sense to me than presumed consent in this context. So with that as a background, we need to consider what are we going to do about the problem we all know we have. We don't have enough donors. This is an option. There's other ways to increase donation. If you're in China, you just take political prisoners. If you're in some parts of the world, you buy your organs. There's no way in the world you can defend these strategies as the right way to increase donation. So the plan we need needs to be congruent with the ethical standards that we all would fight for. And this recent publication briefly reviewed how presumed consent fits in with these well-described and supported ethical principles. So briefly, support for autonomy is congruent with presumed consent in most cases. Most people we know from surveys support donation. They definitely want what they said to have happen with them actually be what happens to them. They want that autonomy respected, although that opinion poll I showed you indicates that may always not be the case. So this might be a mechanism to actually protect autonomy, not to risk it, especially if as part of our system you define some way to opt out. The argument against is that opting out is an active process, and there's some communities that may not understand how to do that. They're misinformed, they're not aware of what their options are. In terms of beneficence, clearly there's benefit to increasing donation. That's pretty clear to potential recipients. I will tell you that the reason I do this is not the recipients. I couldn't care less in a specific sense. In a general sense, of course it's good to increase donation because the recipient's out there. But in the specific sense, it's the family in front of me that I care about, and this helps them. It's not the lens that a lot of people look at donation and transplant transportation through, but it's very relevant. You talk to families who've gone through this, and the opportunity to donate was a huge part of their healing. It frames a legacy of their loved one that they carry forward for decades. It's important to them. That's of value. And if this process increases that, then maybe it's worth it. Obviously, if families disagree and there's distress, that's not of benefit. Do no harm. Well, clearly, using organs that can help people excuse me, is very helpful. And as long as we've got an option to opt out, are we harming people? The issue that does become relevant, though, is that if this imposition, as some people would look at it, fractures the trust between the public and the healthcare system, you have a problem. That is a very legitimate concern in terms of this approach, or at least something worth talking about. Justice, enabling the broader community to have equal access, is dependent on having a better supply, amongst other things. And is it worse to take organs from a deceased person who wanted to be a donor or not take them than the other way around? I think justice is better served by maximizing that. So, what happens around the world? Again, Megan briefly showed you a graphic. This highlights what I had pointed to earlier, and that is that even in environments, well, the next slide will, even in environments where family have the presumed consent countries, family are still consulted. So if you know in a presumed consent environment that the family have problems with that, the majority of countries that have presumed consent will go with what the family wishes are. That hard yes, no matter what, is actually very uncommon. So even in the presumed consent world, the truth is that in the vast majority of times, families still have the opportunity to veto that and enable the donation process to be halted. An important question given all of this is, does it actually improve donation? Do the numbers go up? We won't go through that. You already saw it. This graph sort of clusters successful with not so successful countries. And you can see that in general, presumed consent is associated with higher donation rates, but you can find countries with presumed consent and terrible rates. So let's talk about a specific couple of countries. Belgium has been very successful with a presumed consent option, but it's important to look at their history. They brought this legislation in, but historically, the academic medical centers had been doing autopsies on their patients when they died without family conversations routinely. That was just what they did there. And so to bring in a model that says we're going to take your organs unless you tell us not to was not such a dramatic cultural shift. And what you do see is a fairly significant increase in the donation rate, coincidental with the change in the law. Now they've looked at a comparison between them and the Netherlands, similarly culturally, population density, and you can see that the Belgium's done better. Netherlands have less road traffic accidents, but when you correct for that, Belgium still does better. Croatia has become one of the great successes around the world, and you can see in the last 10 years or so, they've had a dramatic increase in donation, and now they're actually decreasing their wait list. But when you look at their literature and the publication I quoted here on what's happened, legislation was enacted that instilled presumed consent, no quarrel with that. But their conclusion was that the real effect was related to the recruitment of intensive care physicians who were supported, a 24-hour coordinating desk, and financial support, amongst other things. So presumed consent is in the mix, but were there other things more important? This is a Canadian study that looked at kidney transplantation in presumed versus explicit consent countries, and they tried to tease out whether there's a cluster of socio-demographic factors that would contribute. People have said if your country is more Catholic, because of the religious tenets, you're more likely to support donation. The richer countries support donation, a higher density of physicians, and so on. So this group looked at the relationship between presumed and explicit consent, factoring in some of those variables. And what you find, generally speaking, is in presumed consent countries, there's no question donation rates are higher. But it's not as black and white as you might think. This recent publication reviewed all the literature on the studies and highlighted, number one, there isn't that much out there, but the trends are held. That is that in general, in presumed consent nations, donation rates are higher. And looking at the comparisons, 3 out of the 4 country-to-country comparisons, statistically significant in 3 of the 4, 20 to 30% improvement, and they looked at a bunch of other variables that have also been said to be contributors. But the take-home message there, again, is a clear signal that there is better performance in countries that have presumed consent, with the big asterisk being that there's other factors in those countries that are also contributing as well. This recent publication took a fairly complicated way of reviewing donation performance, not worth going into, but a similar conclusion. Roughly a 30% better performance in countries that have presumed consent. And this is Spain. Everybody that knows anything about donation always looks to Spain as the country that has presumed consent and the best numbers in the world. True, related, or true, unrelated. And if you look at what they've done in Spain, presumed consent is part of what they've done, but there is a bunch of other stuff that probably is way, way more important. And when you talk to the Spanish, that's what they'll tell you. It really isn't presumed consent at all. It's all these other very important system changes. And in fact, this is a quote from the publication that reviewed this about a decade ago that shows that 20-25% of the patients' families are still refusing, in spite of the fact their numbers are going up. They're saying in this publication that presumed consent exists. They always support what the family wants. The reason they're good at what they do isn't presumed consent. So what do we conclude? Basically, it is associated with good donation performance, and I think it in some way contributes, but the system that supports donation, including all of the other variables, is really the issue here, not a law. A law in and of itself is not the solution. So why? And this may be one of the most important slides in the whole talk. If all you did was change consent, why do donation rates go up? And if the consent issue was the issue, are you now just basically taking donors from families who are not supportive, who in an old world would have said no, but now they don't get the chance? If that's how our numbers are going up, it's bad. That's the wrong way to do it. But it possibly contributes. What about families who have reservations? They're in the gray zone, and in the old world, maybe they say no. In this world, they say yes. Possibly. I think this next one may be one of the most important ones. When you deal with families who are dealing with this crisis, that bottom line cannot be underscored broadly enough. It is very difficult for them to make good decisions when they're going through the worst thing that they have ever gone through. They're exhausted, they're stressed, they're scared, and we're asking them to make a very difficult decision. And I say this with conviction because there's now, I've done this enough, there is a lot of families who say no, and it has nothing to do with not supporting donation. They're exhausted. They just can't handle it. They know it's good, they want to do it, but I gotta go home. I can't wait another 12 hours or whatever. So I think if you have a presumed consent world, these families may be relieved of that burden, and that may be part of what you're doing. But there's other things at play as well. I think when you invest in presumed consent and nothing else, you've sent a signal to the public that this is kind of important. So maybe more of the public become informed. And we know they support donation. in general, if they get more informed, I think the numbers just go up, not down. That may help. Clearly, the healthcare community, who in general support donation but don't know an awful lot about it, may get better informed if they're living in a presumed consent world. And a more informed healthcare community is only going to help the numbers for a variety of reasons. And this is if you didn't invest another penny. If you brought in presumed consent plus all of the other parts of a better system, it shouldn't be a surprise numbers go up. So if those are the arguments for why not? And this is a summary of some of the concerns raised in the Welsh debate, as well as some other things listed. The loss of trust is certainly a concern. The notion of the altruistic gift, big brother, the government deciding what's best with me and my body and so on, is a concern for some people. This review of why families say no highlights how the presumed consent concern might specifically be problematic. Families who are somewhat mistrustful of the healthcare system at baseline are more likely to say no. We know that from mostly American data. If they feel like this is the government getting involved again and we destroy that trust, that's not going to be helpful if that's what presumed consent does. And not respecting family wishes is of great concern to a lot of people. If they perceive presumed consent as not respecting families, we have a problem. I think there's ways to deal with that, but we have to be sensitive to those concerns. We already know that's why families say no in today's world. In a presumed consent world, we have to address those factors. This is data from Pakistan that shows that mistrust issue is a significant contributor to why people don't support donation. So with all that as a background, I'll fill you in on where I come from in Nova Scotia. I've been involved with this for, 10 years or something now, and we have a pretty good program. Most of it is because of Corinne Corning, who's our manager. She is amazing. And we've been successful because Corinne is really good at getting our community informed and knowledgeable about what we need to do. And we've been able to maintain donor rates over the last 5 years. Our average is 21 per million, which is pretty respectable. Our consent rate is in the 80s consistently. And we've got procurement rates that are pretty good. I'm proud of that, but I really see that we need to be better, not that we've done well. So it may very well have been that last April you heard about this before I did. I'm sitting there as the head of the donation program, and I got a phone call from a colleague out west, who had seen this Globe and Mail article, and that's how I found out that the Minister of Health was announcing to the world that Nova Scotia was considering presumed consent. There was a bit of a breakdown in communication, to say the least. If I had gone on the news and announced that without telling the Minister of Health, well, it's not an even playing field, let's just say that. His heart's in the right place. I met a lot of politicians, some of which I don't care to meet again. He's a great guy. His heart's in the right place, and he thought he was doing a really good thing. But launching this without talking to the donation program was a bit of an issue. We were blindsided by it, and it generated perhaps a predictable response. This was one of the editorials published, and I will just highlight a few of the things that were in her editorial that were really concerning. First of all, her comments around obtaining consent and being unfair to immigrant groups. I can't quarrel with that. That is a potential issue, and maybe we need to be sensitive to that. A bunch of the other stuff she said, I really have a problem with. And the stuff in red, is just infuriating. To claim that the community says that non-donors are ignorant, lazy, or selfish is so irresponsible, so wrong. I've never heard it before, but she put it in paper. And to suggest that what we should do is replace guidelines and talk to a group who are more committed to the safety of dying patients is so offensive. The vast majority of intensivists who are involved with this work, nurses and other healthcare professionals, are spending their life trying to get people better. Donation is a small percentage of what we do. We want to do it right, but most of our work is to make people better. And to think that we would compromise the safety of dying patients to boost our numbers is offensive beyond belief. The thing I really am worried about, though, is that I understand that reality, having been in the trenches, but this is widely disseminated. Joe Q. Public's out there reading that and presuming that this person is an expert or has credibility. And this is one of the problems with this issue. She works a few hundred feet from me, I'm told. I've never met her. She has absolutely nothing to do with the donation process that I'm aware of, has made absolutely no attempt to connect with anybody in the donation world to say what happens. But this was out there. Another colleague took a swipe, although this one was around Big Brother, a reasonable conversation. My point in saying that is that when this information gets out there, it influences public opinion. And if it's based on fact, fair enough, let's just talk about it. But there's some statements that were, call them insensitive and inflammatory, and downright wrong. I did write a responding editorial. I don't know what happened there. So, instead of advocating for presumed consent, as the minister thought we might do, we reined him back in and said that let's have that conversation at a different day, but we're not going to not address donation in Nova Scotia. So what we've instead chosen to do was get proclaimed a law that had been on the books for several years, and that's the Human Organ Tissue Donation Act. And a couple of key things in the new act that I think make Nova Scotia pretty unique is that now we're requiring referral of any potential donor to organ or tissue in the province. And the first person consent is considered legally binding. Excuse me. There's some other things in the act, and we're doing some other provincial program stuff, but we're not doing something to improve things in Nova Scotia. It's just not presumed consent at this point. So my answer was that at this point, presumed consent for Nova Scotia would be a soft no, but I'm not sure that's our future. So why am I saying that? If you look at consent, we've had pretty good consent rates. If our consent rates were 40%, maybe we do need to do something, but they're not too bad. And compared to other successful and not so successful countries around the world, our consent rate's pretty good. So is that the right target? I put this slide together. It's not completely accurate, but it's a pretty good snapshot of what happens in our province. We're a small province. I don't know how many people are in Edmonton, but you probably have more people in Edmonton than we have in the whole province. But if you look at what happens in Nova Scotia, it's probably fairly similar to what happens in Alberta. The majority of people who die in hospital cannot be donors for medical reasons. Of the small percent who might be, our problem is that we're not identifying and referring. Once they've been identified and referred, once our program hears of them and they get into our ICU, we do pretty well. We have, say, the 25 out of the 80 that actually got referred, we can guesstimate at least 20 will be consented, and virtually all of them will go on to donate unless there's a medical problem. So once they get to us at the level of the ICU, we do pretty well. Our problem in Nova Scotia is before that. And does presumed consent change that? I don't think it will very much, although it might for some of the reasons I alluded to on that previous slide that I said was perhaps the most important one. So for the moment, I think there's other things that we need to focus on. And increasing our consent rate may not be our primary target, at least for the moment. And is there a risk to just going full forward with presumed consent? Well, if you look at the Brazilian experience, this is a pretty good example of how not to do a bunch of things. But well-intentioned legislators in Brazil did bring in presumed consent there. Interestingly enough, they didn't have the support of the medical community. The public weren't supportive, but a bunch of politicians decided they were going ahead anyway. And it wasn't very long before things exploded and they had to retract it and change the law. So Brazil is a pretty good example of how you can cause harm by bringing this in. They now have more creative ways of dealing with the donation program. This is sort of clever. It captured the imagination of the country for about a week when this billionaire made it very well known that he was going to bury his $400,000 car. And everyone thought he was insane, but I guess he has a history of these insane things, so they actually thought he was going to bury his $400,000 car. And just as he was about to bury it, he made the point that, burying a $400,000 car when I'm a billionaire, that's not so crazy. But burying my organs when some people can benefit, now that's crazy. That happens all the time, and we should change it. So that kind of a public relations approach actually has been somewhat beneficial. And in Brazil, the way to get to them is to connect with the football clubs, which has also worked. And now Brazil has donation numbers that are still modest by world standards. But that was a good example of a country who took this proposal, which on first glance sounds like the thing to do, completely exploded. The other thing I would point out, and this alludes to a theme you've heard of earlier on, Germany had an excellent program, very well developed, and as you can see, very, very successful. But what you also see is in the last couple of years, the wheels have fallen off. And the question is why, and this is very interesting. I didn't know anything about this until speaking to a colleague who runs the program in Germany. And what physicians there were doing were playing games. They were adjusting the mortality or the acuity of their own patients so their patients would preferentially get organs off the list. And they would rationalize it by saying, I got to fight for my patient. He might die and I'm going to do what I got to do. Well, of course, what it ended up doing was compromising the trust that the public had in the physicians and the healthcare system as a whole. Completely destroyed the trust they had, and you saw that about a 40% drop. And he mentioned that they're continuing to drop. So it does not take much of a change to generate that mistrust, and that is a concern. If we're going to bring in presumed consent and compromise that sacred trust, then we need to think that through. So what do I think is going to happen in the near future? This would be, again, my opinion, and I may have a plan that nobody else will listen to, but I think Nova Scotia should be the first place to do this. I really do. We've got a government that's supportive, a provincial program that works well. We have a population who still have a you should help out your neighbor kind of mindset because you probably know them. I mean, if you go to Nova Scotia, it's ridiculous how everybody knows everybody. That 6 degrees of separation thing it's about 2 or 3 degrees in Nova Scotia. But it explains why we need transplants in some circumstances too. But it's an issue, and it's generally a strength. Our communities want to help people in their community, and when somebody donates an organ, it is front page of the local paper, and they have parades, and it's a big deal. And that culture is a great thing, and it exists, and we need to exploit that. The other thing is that we've got one major medical center, and so changing the world one place at a time is more practical. And we've had a program that's proven to be successful in the last few years. So if we're going to do presumed consent in Canada, why not do it in Nova Scotia? I don't quarrel with that. My question is when, not if. And being blindsided by the minister was not when. It was not the right approach either, but I think there's a way to do it. And importantly is we have to control the message. If we're going down that route, I don't want these people at the law school who are uninformed writing editorials that stir the pot, especially when they're not based on fact. That will scare the public and undermine the work of a lot of good people. If we're going to do this, we need to control the message and make it factual. We're not manipulating the truth, we're just making sure it actually is the truth. We know the public say they support donation. Most of our public are registered donors. In our Nova Scotia, our donor registry has about 55% of the population already registered as donors. We know they want their wishes respected, and a message that really needs to get out there is donation is not a bad thing. We don't need to apologize for it. It's actually a wonderful thing. It's a good thing at a very bad time. And improving donation is good for donor families as well as the recipients, as well as the community at large. The other issue around this, and I've dealt with enough families now to know that I'm not overstating it to say that this is the worst thing these families will ever go through. The death of a loved one is always tragic, but donors are almost always sudden, unexpected deaths. Dad was fine at breakfast this morning, then he went to work, he fell off the scaffolding, and now you're telling me he's going to die. But I was talking to him this morning. Mom was fine, and then she collapsed in the grocery store, and now you're telling me she has an aneurysm in her head and she bled into her head, and she's going to die. Which is different from Dad has had cancer for 2 years and it's finally gotten the best of him, or whatever. I would never trivialize the death of any family member, but these are almost always sudden, tragic events in a proportionately younger population. And the families often have to go through 1 or 2 or 3 days of aggressive therapy. They don't leave the bedside, they don't eat, and now we're asking them to deal with a really tough question. If we respect this wish that we know they had up front, we relieve the burden of choosing, and that's a good thing. The other thing I would point out, in spite of everything I just said, if families have clearly said that in spite of what we've told them they don't want this to proceed, we're clearly in a soft opt-out position. We need to control the message, understand the power of education, and why are we going to educate, who are we going to educate? Well, as we found out, our political leaders have influence but not knowledge. That's an overstatement. They must know something about something. But in this field, they don't know much about donation. College of Family Physicians, again, the majority of family docs out there are respected healthcare advocates who the community want to hear from. Most of them know nothing about donation. It's not in medical schools, it's not in residency. It is now, but 10 or 15 or 20 years ago it wasn't. So we need to connect with them. The Emerge guys are frontline gatekeepers. We need to get them educated. And most of the ICU beds are staffed by internists, not trained intensivists. So my objective would be to get the message out to people first, educate them. Why do we have to educate them? Well, there's a surprising lack of knowledge in the medical community around this topic. Belgium has one of the highest donation rates in the world and has had this for a while. This is a review of pretty straightforward questions around brain death and donors given to physicians in Belgium. And as you can see, depending on the question, surprisingly poor knowledge around this topic. And this is the resource that the community will tap into. And this is in a country that has donation as very high profile. This is Australian data that sort of shows the same thing. These are frontline emergency people. Interesting that these are frontline people, and you can see, there's a quarter of the people there who think that if you're brain dead, you can breathe without a ventilator. Why does that matter? Because if you look at the people that did this test and ask them, are you competent to talk to families about brain death? Most of them think they're competent. And we know from a very simple 5-item test that they did that there's a lot of knowledge gaps. They don't even understand the gap that they have. And if that's the frontline healthcare resource, then our population are going to get the wrong message. So we can get them up to speed fairly quickly, but we do need to do that. That's why I said educate, not legislate to start with. This is public data. Half the people out there in this survey, it's American, but thought that if you were going to be a donor, the healthcare team's not going to try as hard to save your life. Absolutely, completely false. But that message is out there. Black market exists. And this 61% recover from brain death, this drives me nuts. When you're dead, you're dead. And 60% of the people think you can recover. Well, bear in mind that this Tom Mones is from California. California had this case, you may have remembered about a year and a half ago, that poor young girl who had an ENT procedure that went horrendously bad. And this young 13-year-old child was dead, declared brain dead. ME signed off on her, all that stuff. She's been supported in a hospital in New Jersey, quote unquote. Her corpse has been supported in New Jersey for months. Well, what does the public think when they hear that? So the misconceptions out there are significant. And if we're going to bring something in, we need to be aware of it and we need to deal with it. So educate the key parts of the community. The second part is respect those who disagree. There will be a small but real percent who are going to hear everything you have to say, any way you want to say it, and they're still going to say no. That's fine. I have no problem with that. If they're informed, we should acknowledge that they have the right to disagree. The family will get whatever support they need one way or the other. That's total given. And if they have complaints, we need to address them. The most important thing, and a reasonable criticism if we did not put it in place, in Nova Scotia, illiteracy is very common. Not many people who don't know how to read go into a conversation with you volunteering that. They nod their head politely. You tell them, feel free to, search the internet or whatever you want, right over their head. But it's very difficult for a lot of people to admit that they have those problems. If we're going to develop a tool this important and we're not sensitive to the cultural challenges that people in the immigrant community might have, English as a second language, just people who aren't well educated and are illiterate, then we got a problem. But I think we can develop a tool that's sensitive to all of that and allows the community to opt out. And if we've done that, then we've respected that percentage of the population that just don't want this to happen. And the third thing I'd say is before we initiate this, plan for the surge. We didn't do this for tissue donation. For example, we changed some. We got all these phone calls that said we want a bunch of tissue donors, and then we didn't have the infrastructure in place. No. If we're going to start this, part of our solution is to plan for success, which means that we don't have a phone call for a potential donor and we have to tell the guy in Cape Breton that, you know what, we don't have an ICU bed, because they won't make a second phone call. So we need the infrastructure, we need the people to support this, and we need to have a system that enables us to measure our performance. I think doing all this is a pretty modest investment, but it's part of what I would say our solution for bringing presumed consent in. And when we do all that, then we blast off and we see what happens. And I'm done.